When I was asked to do this, I think this is a diagnosis I frequently encounter with my primary care and consult patients. And sometimes I'm the person who's diagnosing it or delivering the news of it. And, the lesson I learned very early on in my training was um, when there's an emergency, the first pulse you have to take is your own. And I think it's really important for us that when we hear this kind of life altering and changing news, right now in the moment, we're okay. And we're going to work through this and we're going to get a plan together because the overwhelm can really sneak up on us. So I'd like to start with two patient stories. So this one is about Sandy. She is a retired 74-year-old former school administrator who has been noticing that she's more forgetful of late. She lives alone since her husband passed away a few years ago. She's still driving, but has stopped going onto the highway and really doesn't like to drive at night. Several times now, she's had some trouble getting lost and had a small fender bender in the grocery store last week. At church, she's having a hard time remembering the names of other churchgoers and feels quite self-conscious. Her daughters have noticed that she is not cooking like she used to. She was a fantastic cook and entertained all the family holidays. Sandy tells me that she can't be bothered to cook a big meal for one, and microwave and takeout is just easier. She goes on to say that there have been a few times when she's left the gas stove burner on, and that makes her concerned. Now we'll move on to Dave. So Dave is a 76-year-old retired bus driver and veteran. We are seeing him for an annual checkup. He lives at home with his wife, Nancy, and their two dogs. Dave feels that he is doing physically well and tells me that he's exercising several times a week and keeping himself busy with his hobbies, including a record collection and bowling. Nancy rolls her eyes as she makes eye contact with me. She takes me aside while he is getting routine blood work and tells me that Dave has not been a part of his bowling team for over a year. He hasn't really left the house for several months since their kids took his car keys away. Dave had had several episodes of getting lost, and the last straw was having the state police call her when he was found at the state border. He's more forgetful and gets angry at her when he misplaces things in another room. Now, when we hear about somebody developing cognitive impairment and then dementia, a whole host of things can go through our mind. Sadness at the loss of what might be happening, worry about behaviors. Where can we live? Is there going to need to be extra care? How are we going to work with the money, the finances, all of these things? And they're all circling around. So when we want to bring a structure to this really challenging experience, it's important that we understand the disease first and foremost. So I mentioned the term mild cognitive impairment or cognitive impairment. So dementia is deficits in two or more domains of your brain functioning. And this last part here at the bottom must be severe enough to interfere with a person's ability to function. So for Sandy, she is having trouble with visual spatial stuff. She is having trouble with recall, and it is starting to interfere with her ability to safely function. Similarly, with Dave, he is actually not aware of the problem, which is in and itself a problem. And that's called a noonosia. I don't know that I don't know. And that is interfering with his ability to drive and to interact with people. He has no short-term recall, and he's attributing losing items or not finding items to someone stealing them. So you see this sort of paranoid, almost like behavior. So dementia is the umbrella term that's applied to various disease states that can cause this outward appearance of the brain not functioning in two or more domains. And the subset of those types of dementia, you've heard of Alzheimer's disease, which is a buildup of plaques in the brain. You've heard of vascular dementia, which is the consequence of longstanding high blood pressure, high cholesterol, causing little injuries to parts of the brain. Lewy body and frontotemporal dementias are specific, and they're a little bit more symptom identifiable when we come across them, and they are treated somewhat differently in the care and understanding. So there are stages of dementia, and having dementia and being told of a dementia diagnosis today doesn't mean that you're going to be at stage 7 tomorrow. I think that's really important, that this is, unfortunately, a progressive and terminal disease that we cannot change. But we know that the progression tends to occur over the period of 7 to 14 years on average. And when someone starts to have challenges, like around stage 2 or stage 3, like Sandy, we have to start thinking, okay, how are we going to create a world that works for her, that's safe for her, and also for Dave, when we start to see some behavior things, how are we going to create a world that's safe for the caregiver? I'm sure we have done a very great job of disseminating the 4M framework in geriatrics. And this was originally a way of explaining what does a geriatrician do for a living, because a lot of times people would say, geriatrics, is that skin? And we'd have to say, no, it's not skin. it's taking care of older adults. But like, how is it different? So we are the lumpers rather than the splitters, meaning we're not so much focused on a particular disease state. We're not looking just, say, at someone's arthritis or their Alzheimer's disease. What we're looking at is how is this impacting them in the matrix of their life, in the realms of how are they doing for themselves functionally? Are they walking? Are they able to wash and dress themselves? Are they having any challenges of mobility? Similarly, how are they doing cognitively? Are they having undiagnosed depression happening along with some cognitive impairment? Are there other things that might be impacting their ability to safely make sound decisions? It goes without saying that one of the M's in geriatric medicine is medication management. A lot of our patients, it is not their first time at the rodeo when they come to see a doctor. They are many times on greater than 10 medications. The more medications a person is on, the more likely that there will be challenges around compliance and the higher risk of adverse interactions and effects. And lastly, the last M is matters most. What matters? And the reason that we spend a lot of time on that particular M in geriatrics is because everybody is exquisitely different. And it really matters where a person is putting themselves on their life story and how they frame where things are at, so that I'm going to do as much as they want and not something that they would not want. And while that's helpful for me as a doctor, it's also really important for patients and families to talk about what matters most, independent of what goes on medically. So again, mentation, we think about things like dementia or depression. How is this person? Is there anxiety? Is there PTSD? A lot of people can have undiagnosed learning differences that rear their ugly heads when they start to decompensate in some other ways. And when I say learning differences, I mean things like dyslexia or ADHD. Many of our patients need to be hospitalized. When you are hospitalized and you have underlying cognitive impairment, you are at increased risk for having what's called delirium, an acute change in your mental status where you are not yourself, you are not at your baseline, and you may have a different level of consciousness, meaning you might be really lethargic and sleepy, or you might be really agitated and hypervigilant is the word. And you might have trouble focusing on what is being said to you. And lastly, you may have disordered thinking, meaning you may have hallucinations, paranoia, all these kinds of things. But these three things, dementia, depression, and delirium, are very much a psychiatric diagnosis kind of thing. But when we think about, for ourselves, what is so important for us to stay intact and vital mentally, it is really also about not only the things that we do for our own mental, our own cognitive skill sets, but also what we do in connection with others. Because the tendency to withdraw from society in the setting of cognitive impairment is very great. People feel embarrassed, and that actually goes to a way of accelerating the decline. And so we really want to think about this as we talk about how do I plan. So maintaining cognitive function is everyone's goal. And this is going to progress and certain functions will be lost. But we can impact some of the rate by keeping our minds active and engage the many different parts of our brain into different skills that we may have. So for example, I'm terrible at math, but I'm great at the piano. Maybe I do some simple math work and I play the piano while I still can. You're building up reserve, cognitive reserve, so that you have other compensatory pathways in the event that one of the pathways that you've been relying on heavily starts to fail. It is really important to start to prepare for the loss of certain cognitive skills. So people who have achieved very high levels of intellectual achievement, my mind is my pride and joy, and now my mind is being impacted. How will I frame this? One, we hope people will frame this in a way of saying, what are the skills that I can retain, that I can still celebrate? And how do I create a world where I'm not going to be coming up against the lost skills that I have, which will only lead to further frustration. For patients, it's hard to anticipate and manage mood changes. That's where families and caregivers are often struggling the most. You're having to study your loved one in a new way and say, some things set this person off, whether it's the time of the day, or if it's something on the news, or if it's a particular kind of movie that we're watching. Something is doing this. So how do I manage this? Or he gets cranky in the afternoons. I know that that's a consistent thing. How can I prepare a world where we can head that off and stay in a pleasant space? You'll often see M's interacting with each other. So I've got medication in here with mind because it's really important for us to ask, is there anything that the healthcare world, are doing to make someone's cognition worse? So I'm going to look at their medication list. So what are things that could accelerate cognitive decline, and what are things that might be beneficial to slow cognitive decline? The things that I'm thinking of is a lot of times people have trouble sleeping, and that's common as we get older. And people will go to very far ends to find something that works for sleep. most sleep medicines are red flags for geriatricians because they come with side effects of confusion, lethargy, falls, and progressive cognitive decline. So the tranquilizers of old, the benzodiazepines, the over-the-counter sleep aids, all of those medicines actually don't help cognition. They actually make it worse. And similarly, when someone has uncontrolled blood pressure and they have vascular dementia, something that could help slow the progression would be getting their blood pressure medicines on board to help manage the fluctuations in blood pressure. Cognitive stimulation is important. And if there's one thing that we all know in geriatrics, it's a use it or lose it phenomenon. If you are not exercising a part of your brain or a part of your body, it will atrophy. And that doesn't just mean I'm going to do Sudoku for the rest of my life, or I'm going to do crosswords. What I was getting at is you have to use all of the different parts of your brain. So whether it's problem solving, to just see if, okay, I'm able to do this, we can work on this problem together, puzzles, listening to music and discussing poetry, or socializing with people, and especially people that are close friends who are aware perhaps that you might have some cognitive issues and don't care because they love you. All of those things are actually cognitively protective. Now, many people will say, well, if I do crosswords and things like that, will it help? Yeah, it can help. It definitely can help keep your mind active. But there is no one exercise that's going to keep every part of your brain firing on all cylinders. And that's why we always encourage people, think about ways that you can use the different parts of your brain function. So we always say, engage, don't withdraw. People can feel very self-conscious when they have a memory trouble. If they're having behavior problems and they're acting out in public, that's one of those times where it does make sense to restrict the activities to a more familiar surrounding for the person, because their pre-dementia state would be maybe horrified that they were doing these things. So eyes open and ears open, looking for those inflection points where we say, oh, the socializing worked, but now we have to scale it back or reframe it to be in a more familiar environment. Barbara, I don't know if you guys have ever taught the habilitation model that Joanne Koenig-Costi wrote about. You're muted, but
we talk about it, but please not
okay,
to
good.
these people.
So this is, one of the things that is very frustrating for a provider to see is sitting in a room with a patient with dementia and their adult child, and they're saying, Dad, remember? Dad, remember? Dad, remember? And Dad doesn't remember. And Dad doesn't remember that he forgot. And so that's a great teaching opportunity for me as the doctor to demonstrate the habilitation model, which is Dad has lost his short-term memory. So asking him to retain information is not going to go well, and it's going to cause raised voices, frustration, and it's not going to get you where you want. So these are the parts where you quietly compensate for Dad's memory problems, and you write things down and you check in and say, oh, that's great, we're going to do this. And when he asks again, you say, yeah, that's great, we're going to do this. These are ways to make it okay for the patient who's not focusing, because there is an awareness, I've lost a skill. And so we're not going to bring focus on that. Instead, Dad continues to have a great singing voice. And, it's not quite the same. Sorry, my heater turned off and I'm in an office after dark and they turned off the heat and it's freezing outside. So I apologize. I'm like Bob Cratchit hovering over this thing. I had an uncle who, when he would go on a rant, now this had nothing to do with cognitive impairment, but when he would go on a rant, all the nephews would sing the French national anthem because he loved the movie Casablanca. And he would start singing it, and then he would forget what he was talking about. And it was always very effective. And so I say, whatever your version of La Marseillaise is, I highly encourage you to learn that. That takes time to create a world in which the patient is able to function with the remaining skills and not facing those lost skills as much. And it's about meeting the person where they're at. Next, we'll move on to mobility. I tried to find a truthful exercise picture from the clip art, but this is the best I could get, where everyone's smiling. I've never been in an exercise class where everybody's smiling. Usually they're, giving a foul gesture to the instructor and exhausted from what they're doing. But when we think about someone's ability to do for themselves, we think about their ADLs and IADLs. So ADL stands for activities of daily living. And what that is that's the stuff you can do when you're a first grader. You can get out of bed, go potty, wash and dress yourself, brush your teeth, etc. You're pretty much independent in that. IADLs are called instrumental activities of daily living. Those are things you do when you get your first apartment. So you're cooking, cleaning, paying your bills, arranging transport for yourself to and from work. You're making your phone calls, you're doing your finances, and you're managing your medications. We also look at someone's mobility in terms of their ability to stay upright. Are they having falls? Are they having trouble walking? You've probably, if you've been in a geriatrician's office, you've probably been asked to walk or at least get up and walk to the exam table with the geriatrician intently looking at you. We screen for the syndrome of frailty. So frailty is a decreased reserve, the body's total decreased reserve to an insult. In other words, if I get a cold at 25, I can still maybe go to work. If I get a cold at 85, my body is not going to be able to do my usual routines. I'm feeling lousy. It's affecting my muscles. I just feel weak as a kitten, and I am not stepping out 1 foot outside of this house. Having a cold doesn't make you frail, even if you're at 85 and not wanting to leave the house. But it just speaks to the fact that just by nature, as we get older, we have decreased reserve. And as we acquire more conditions and more medicines, that adds to our frailty risk. But then the very real thing of, I know you can move around, but where do you live? And what is the layout of your house? So I will have patients who say, we live in a townhouse in Wilbraham. Our daughter lives in Boston. Okay. This is a concern if someone has cognitive impairment and we're worried about mobility. Okay, at some point, this person with cognitive impairment, dementia, is going to have challenges walking and navigating stairs because that requires a complex physical activity that the brain may not be able to support. What is the plan for possible one-floor living? And I mentioned the Wilbraham to Boston thing is your support system is very far away. Where is the plan? What is the plan going to be as this progresses? And say the spouse who's at home with the patient, with the person with dementia, that person is isolated. What are we going to do to support that person? So understanding location and layout of a home and thinking earlier on, hey, how is this going to play out? What is the one thing that every person with a cognitive impairment diagnosis, dementia, demands of their family? What is the one thing that people always say? And feel free to write it in the chat function if you don't want to say it out loud. Don't ever put me in a nursing home. Okay? I made a promise to my parent that I would never put them in a nursing home and I would keep them in place. There is, in fact, no place like home. And it's also an important thing to understand that the dementia process can become progressive to the point that the home is not able to support it sometimes. So what are things that we can do to slow our loss of mobility. So these are the CDC recommendations, the previous CDC. I apologize, I don't know if it's been updated recently. Adults age 65 and older need 150 minutes a week. So that's 30 minutes a day, 5 days a week of moderate intensity activities such as brisk walking, or 75 minutes a week of vigorous intensity activities such as hiking, jogging, or running. Clearly, this was not for a New England winter. But also at least 2 days a week of activities that strengthen muscles and activities to improve balance. So this combination of exercises is offered at most senior centers in one form or other, or online. For those of you who are not aware of Senior Planet, that is out of the AARP, they have Monday through Friday exercise classes on a Zoom link where they do various things like Tai Chi, flexibility, mobility. Obviously, talk to your doctor before you do it, but there are online exercises. And people with dementia in early to middle stages can fully participate in these activities as tolerated. And there are physical therapists and occupational therapists and all sorts of folks who can help people carry over these exercises, even if their memory isn't great. Because if I've got a strong person who's walking well and has good balance, I'm helping prevent falls. I'm helping them even when they do fall from breaking something. And knowing where I am in space and being aware of my balance and position is helpful at reducing fall risk. But again, the temptation can be to withdraw and to sit and be passive in front of the television rather than getting up and exercising. It doesn't have to be a marathon. It doesn't, I mean, hiking, jogging, or running, that's delightful, but not what I would say most patients in this age range are going to be doing. But walking on a treadmill at the gym, or using a cubie in the house, which is the little foot pedometer thing that you pedal. Sorry, not it's ergometer, foot thing. That can be quite helpful. And then you have to also think about what are the home safety issues that might be going on. Is it well lit? Because as my dementia progresses, I may see light and shadows differently. I will have depth perception challenges. So I need to make sure that the way is very clear, that there are clear signs and paint to hold on to rather than Victorian wallpaper, which can feel like an acid trip. You know, you want to make sure that this person is able to navigate the world. And adaptive equipment. So making the grab bars easily identifiable and accessible in the bathroom and the shower, in the toilet, all of those things can be quite helpful. What is the health of the caregiver? If it's a husband and wife, or a married couple or a partnered couple, we have to ask that question. Because sometimes the person who we've just diagnosed with dementia might be the caregiver for a more frail spouse. Or they may have an adult child with special needs. And we have to know, what is it going to be like in this care situation? How are we going to keep the whole care network intact? We need to know if this person lives in an elevator building, if there are stairs, and we need to figure out who's paying the bills. How are the bills being? Some traditional in relationships, one person is the one who pays all the bills, and the other person has no clue, has never had that responsibility. But now the person who's paying the bills has paid the bills 4 times this week. And the bank is calling and saying, how do we help that person who is now having to step into that role of oversight not disrupt and offend that entire lifelong relationship they've had with one another? Aging in place is commonly what most people desire. I don't want to lose my home and the things around me and my familiarity and my neighbors and whatnot. But there has to be a feasibility study. You have to actually say, is this going to be realistic? If you are a singleton and you are living alone in a large high rise and you start to have cognitive changes, who is looking out for you? There may not be anyone. And so that's the part where we have to say, okay, let's plan for a more supportive living situation. Perhaps there's, an adult child who has the in-law apartment or the ADU, as we call it, accessory dwelling unit that Boston is all about, and I think Cambridge too, where someone could still live and have their own space, but there's family nearby. Because living alone with the diagnosis of dementia is time limited. So moving on to medications. Polypharmacy is a Greek root word, which poly means many, pharmacy means drugs. So it isn't just about the fact that a lot of folks, as we age, we get put on a lot of pills. The pills can have complex dosing times. I have to take this one on an empty stomach at 6 a.m. I can't take this one for 30 minutes after I eat. I have to do this upside down by the light of the full moon, whatever. It can be very frustrating. And especially if you start to have cognitive issues or you're having to manage someone with cognitive issues who may no longer be willing to take the pills in the afternoon because they're having some behavior issues, you need med simplification. So we want to reduce the frequency of some of the medicines, focusing more on the essential things and also recognizing it's about prognosis. I may have dementia that gives me, an estimated life expectancy of, 7 to 14 years, but I may also have emphysema, which is very severe, and that is going to give me a lower life expectancy. So some of these other medicines for my other conditions may no longer make sense. Understanding the risks and benefits of medicines for behavior is very important for a caregiver because caregivers have to sleep. This is a 24, the joke is it's the 36-hour day. This is a full-time plus job. And if someone is awake at 3 o'clock in the morning and agitated and you haven't slept in 2 days as the caregiver, this is going to be an insurmountable problem. So having the conversation with the team of doctors involved in dementia care, so not just the geriatrician or the primary care doctor, but also the psychiatrist. How will we manage if the symptoms get out of control? And who is my lifeline? Many patients, despite having a diagnosis of dementia, will insist that they continue to carry on either their finances or carry on their medication administration. And that's fine. We want people to be involved as much as possible and not put on the sidelines prematurely. So we want them to participate as much as they're safely able to, and we want to have oversight. So we're checking for things like compliance and supervision. So some strategies for optimizing a medication regimen. We want to look and see, is this person eligible for medical therapies for dementia treatment? There are some treatments out there now that are being used to try and slow down the rate of progression of dementia. One of these was pushed forward about 3 or 4 years ago, in a way that did not sit well with academic medicine. It seemed like the data were skewed and the medicine was not all that it was promised to be, and that they've stopped making it. But that class of medicines to attack the beta amyloid plaques, which is one of the mechanisms of Alzheimer's dementia in the brain, that has been approved. And that involves an extensive testing for the patient, including a spinal tap, and serial MRIs of their brain, and then an infusion that is, I think, every 6 weeks that is associated with significant side effects. And as with most things related to dementia-specific medications, the benefit is slim to modest at best in the current state of the science. The risks of some of these medications in many of my patients outweighs the benefits. And it is sort of like, well, what are we going to do? And so this can sometimes feel like this class of medicines can feel like the boil water. Someone has to do something. But we want any treatment to actually have not just a clinical rating scale significant change, but an in vivo quality of life way where we say this person's cognitive status has actually been maintained or improved. And we've not yet gotten to that point. But the hope is that with this class of medicines and fine tuning, we may eventually. But understanding the limited efficacy and side effects is so important. We need to look at medication management for necessity and adherence. When patients start to experience memory problems, in addition to perhaps seeking medical advice and medications, they may also fall victim to high-dose vitamin scams or proprietary supplements. And at best, these things make for expensive urine. And at worst, they can have deleterious interactions with prescription medications and also with metabolic concerns in the body. So I always like to encourage people not to rely on hypervitamins, but rather focus on a better diet. And I think one of the things we'll talk about here is food is both medicine and toxin. So we'll often say, oh, don't eat high salt processed foods. We all know that. But can food be actually beneficial? And yes, it can. You know, eating a Mediterranean style diet or the MIND diet is actually protective, neuroprotective, and that's really important. Lastly, we want to think about the lifestyle factors. So alcohol, tobacco, and substance abuse. So like all tranquilizers, alcohol is associated with more progression towards cognitive decline and associated falls and other kinds of things. So it is sometimes the leak in the bucket in somebody who we are trying to shore up, but they're continuing to drink alcohol on a regular basis. Tobacco is, smoking has been made anathema in most slices of our lives. And so the temptation is not there as much, but in our own home, perhaps tobacco is a little bit easier for people to reach for. And we don't recommend it because it can certainly lead to inhaled tobacco, can lead to problems that could accelerate vascular dementia. So now we're just going to move on to the matters most. So perhaps figuring out what matters most matters most. And this is work that we can name and help put on patients and families' radars, but the work is not, I'll say this as a doctor, the work is not mine to do. How is this person going to seek meaning, find meaning and legacy in the face of this? And I've had patients make recordings for their grandchildren or make extra efforts to be a part of grandchildren's lives who they weren't necessarily as involved with because they wanted to have a memory with them. Addressing hopes and fears and worries. Who am I if I am not my intellect, Who am I if I'm not the breadwinner? Who am I if I'm not the head of the family? All of these things are challenges to our identities and our roles. And how can I work through this? And how can I reassure myself? And those hopes, worries, and fears and challenges to roles extend to the entire family care unit. It isn't just the patient that's going through that. I now have to step up and be the caregiver for my parent. This is a very flipped role for me. I'm not necessarily comfortable with this. Where I live and how I seek my companionship is going to be key. You know, we put Dad in an assisted living for his safety and cut him off from his very connected local neighborhood where everybody knew him and was keeping an eye out for him. These are things that well-meaning families have done and have regretted. So really understanding for this particular person what can be done in the home with the goal of hopefully keeping them at home, because that's what most people want. And sometimes it also means that we have a little bit higher risk level for the sake of this person's sense of self. And we also need to think about the caregiver support, because from our standpoint, if the caregiver is so focused on the patient, in our case, the patient, that they're neglecting their own health. They're not going for their regular routine medication checkups. They're not getting their blood work done. They're not getting out and socializing. Their health status suffers. If you have been a caregiver, your health is going to be, your health status is worse than someone who was never in that role. That's just a well-researched fact. That doesn't mean don't ever be a caregiver. It just means we really need to focus on supporting people who are in that role. So how do we talk about what matters most? One thing that is absolutely has to happen much sooner rather than later is making sure that a person's wishes are absolutely placed on legal documents. That the diagnosis of dementia means we need to discuss and document preferences for future care. So one thing is, I have cognitive impairment, now dementia. I'm going to lose my ability to make decisions for myself somewhere down the line. And I need to know who that person's going to be. I need that to be someone I can trust, someone who understands my journey, who understands my values, and who has the fortitude to respect my wishes rather than doing what they would want. And if you have not had that conversation, it needs to happen. You need to say, hey, what's most important to you? Like, what is quality of life to you? I could ask all of us in this room to write down what quality of life is, and we would have, as many different answers as there are people in this call. So we need to say, okay, tell me what that means. Who will speak for me? It might be, I chose my spouse. Well, my spouse falls apart in an emergency situation. And as this is getting worse, I don't think that person who I care about would it would be cruel to put them in that spot. So maybe I pick my oldest adult child. Similarly, for financial matters, I need to make sure someone is in charge by power of attorney if I lose my decisional capacity for financial matters. Many patients with dementia are still driving. And so we need to have the hardest conversation, and I would say it's the hardest conversation, is retirement from driving. The fact of the matter is, if anyone was on our geriatrics town hall a few months ago on driving, men outlive their driving ability by 7 years. Women outlive their driving ability by 10 years. So there's a time period where many times people are behind the wheel who should not be. And driving is freedom, access to the rest of the world, errands, all of these things. And you can't minimize the impact that we're a car country. And especially if I don't live along public transit, this is my only way to connect to the rest of the world. So I'm going to hold on to those keys as long as I can. But that is an important conversation. Every patient I've ever had this conversation with has said, I would never get behind the wheel of a car if I thought I would hurt someone. There's an intrinsic logical flaw to that when you have dementia, because you need to have short-term recall, visual spatial, and attention skills. And those three things are often very much attacked by the disease state. So who's going to come into my house to help me if I need help? Is it going to be a family member? Do I have family members? A lot of us don't. A lot of us don't have someone that we could get nearby. Maybe I need to professionalize this. Maybe I'm the caregiver and I have to work a full-time job and I can't keep taking time off, because this happens. Dementia is a costly disease and it costs the caregivers, especially if they're still in the workforce. So how will we have increased supervision as the dementia progresses? Because I have poor safety awareness, I'm frail, I have a fall risk, or I might be at risk of wandering. And lastly, I always talk about mitigate the risks of financial exploitation. So getting rid of some of the ways that scammers get to us, disabling the email perhaps, or disabling, putting a credit lock on someone's credit cards, or canceling their credit cards, letting the bank know that this person has cognitive impairment. Any charges over a certain amount, please, hold them until review. Some patients are very defensive about their finances, and often for good reasons. They may have heard nightmare stories of people exploiting older adults for money and whatnot, and so they don't want to give up that thing. And add dementia to the mix, where people have increased paranoia. My kids are trying to take my money. These are things that we need to have the conversation beforehand and just say, Dad, I'll take care of the bills, or the bills don't get sent to Dad anymore. It's all on auto pay. So we talked about the legal planning, durable power of attorney, Massachusetts healthcare proxy form, and lastly, the Massachusetts order for life-sustaining treatment. If any of you have seen this Japanese food menu, the magenta form, this is the what I like to call the documentation for the larger conversation that was hopefully had more sensitively than, do you want resuscitation or not? Would you like fries with that? This is really about, in an extreme situation or circumstance, when the chips are down and the doctors have to make emergency decisions to do CPR or perform, put someone on a respirator, a ventilator to keep them alive, do they want that? CPR was invented for people who have heart attacks, 50-year-olds on the tennis court, to get them back in to hopefully replumb their coronary arteries. As we age in the United States, most of us aren't dying by cardiac arrest. Most of us are dying from other conditions. So when we restart the heart, we haven't fixed the underlying reason why we're passing away. And this is especially true in dementia. So there may be values at play where people say, I don't care if I'm on a machine, my heart is vital, keep me going, it is in my values. And that's fine. But too often, no one's had the conversation about what are your values and what do you want? And what would be an acceptable way if you were coming to the close of your life for that to look? Some people say, listen, I've lived a good life, I've contributed, I've raised my family. I do not want to spend the last few days of my life on machines. If my heart stops or I need to go on a breathing machine, do not do any of that, just make me comfortable. So that's all well and good in an emergency situation. But dementia is a glacially moving disease process. And there are other considerations around what I would be willing to do in terms of, say, feeding. As dementia progresses, people can lose the ability to safely swallow food. They might choke on it and it goes down into their airway, into their lungs. That just has to do with the voluntary coordination of forming a nice food thing and sending it to the back of your throat and swallowing it. So what happens when that person loses the ability to swallow? We used to think that putting in feeding tubes would help, that putting in a feeding tube, which is a tube that goes through the stomach wall, through the belly wall into the stomach, would help. But our research has shown, unfortunately, that it just takes away the personal touch of feeding, which is companionship, and it causes other abnormalities of peristalsis that cause people to die at the same rate as people who are just on what's called pleasure feeds. So these are all things that we've talked about, but it's good to talk about when the emergency isn't front and center. And sometimes people can have an easier way of manipulating the information when it's not so scary and in front of you. We are trained in what's called the serious illness conversation to talk about what matters most. There is, through the Continuum project here, a Prepare for Your Care event, which is actually teaching patients and families how to talk about what matters most with one another, how to choose a healthcare proxy, and how to let the rest of the family and friends know why you've chosen that healthcare proxy and what's important to you, so they can be not a peanut gallery, but a support to the healthcare proxy. Lastly, I'll just say patient and family education is important. We want to support our caregivers, recognizing that they need to understand when they might be burning out, helping get professional care in the home when they need a break, disease education, supportive environments, helping understand what are the options beyond just home or nursing home, but what are the things that can happen in between. So how do we address caregiver support and our needs? We ask them to learn strategies for managing the annoying behaviors that can cause caregiver burnout. We have to have the caregiver recognize that one person will never be able to provide 24/7 care. In sickness and in health, we've married, I've been with this person my whole life, this is what we do. Yes, and you're going to make 2 sick people happen, not just one. So it is important to say, you cannot do this. No human being could do this. That's why we encourage exploration of professional care options as the care needs increase. Okay? And again, just prioritizing, you also need to be healthy. You also need to have your well-being, going to your appointments and doing the fulfilling activities that mean for you. So driving, cooking, falls, wandering, all of that are important considerations as dementia progresses. What happens when someone is leaving the stove on? Do we disable the stove? Do we remove the stove? Do we cut off the gas line? Do we just have a microwave and an electric kettle? How do we manage falls? What happens if there starts to be wandering? Okay. Finally, it is a very expensive, it is a very expensive disease state, and the costs increase as people age, as people live longer with this disease. And so meeting with a financial advisor sooner rather than later to look at options in ways to protect the estate, but mainly being able to support the person and not have money that is gifted away and no longer accessible to a family member or to a patient. And again, thinking about how the caregiver's employment might be at stake. So ensure all accounts and credit cards are known by a trusted loved one. I usually tell people freeze the loved one's credit score or credit lock. Place a second person on the accounts, a trusted person. Complete a durable power of attorney think about downsizing, plan for help in the home, and estate planning. I'll finish with just a little postscript. So Sandy was screened for cognitive impairment and was found to have moderate deficits in visual spatial awareness and short-term memory. She voluntarily underwent a driving assessment with an occupational therapist who recommended she stop driving, and she agreed. Fearing resultant isolation, her daughters are taking turns taking her mom to church and running errands. In addition, they are cooking together on Sundays to prepare meals for the week, which mom only needs to reheat in the microwave. Her medication list has been simplified to once a day in the morning, as this is when she's most reliable. Sandy has also started attending a local senior center adult day health program a few days a week with subsidized transportation. Dave was diagnosed with mild to moderate dementia, likely of Alzheimer's type. He also screened positive for major depression and B12 deficiency. He was started on a non-sedating antidepressant and vitamin B12 supplements. A trusted family friend and former bowling teammate takes him out to Dunkin' Donuts 3 mornings a week, where he meets with the other guys from the group. He goes to the VA gym once a week and participates in a supervised exercise program. At home, Nancy plays some of his favorite records and they dance before dinner every night. This has helped his mood a lot. So I know this was a lot, and dementia is a moving target, and it requires frequent adjustments and course corrections. The 4M model can be very helpful in helping families figure out where the lump of my challenges lie. And it can help guide you in each of those domains. It is so important to understand what matters most and the patient's identified goals, because the medical model will fail. And if the patient has a clear understanding of their expressed wishes and the medical model understands that, there's a greater chance that they're going to receive care according to their wishes. So with that, I will stop sharing.
Yeah, thank you, Matt.